So, a 22-year-old woman with Crohn's disease is taking prednisolone 30 mg daily for more than 3 months, and she now requires an emergency subtotal colectomy. So, what is the perioperative steroid regimen for this patient? This is a high yield concept that regarding the perioperative steroid cover in what type of surgery, what is the amount of steroid that should be given intraoperatively, preoperatively, and postoperatively, and after how long, after specific days, that amount should return to the oral medication. Now, what should we do in this scenario? We do not give any additional steroid. We continue with the oral prednisolone only, hydrocortisone 50 mg followed by 50 for 72 hours, hydrocortisone 25 mg, then continuing with oral steroid, or hydrocortisone 25 mg IV pre-op, then 8 hourly for 24 hours. So our scenario states that the patient is having a major surgery and they require coverage of the dose. So we have dose of more than 25 that our patient was having 30 milligram, and the second scenario that you need to establish is the type of surgery. Okay, so in our scenario the type of surgery is also a major type of surgery, just to correlate with the concepts. So for the minor surgery, if the patient is taking pre-operative steroid, you will shift the patient. Now, what is the drug? That will be the hydrocortisone. It will be given intravenously. And third thing that is important is the amount. That is 25 milligram, and that is given only at induction, and we will resume the oral dose whatever was present pre operatively. We will start the patient on the oral dose as soon as they break their NPO. Now, for the moderate type of surgery, which includes cholecystectomy, again the drug is hydrocortisone. The quantity is 25 milligram IV at induction. Now, in addition to this, you will also add 25 milligram every 8 hourly for the next 24 hours after surgery, and after that you will add the oral dosage whenever the patient breaks their NPO. Now, for a major surgery, which is in our scenario, that is the colectomy, now what we have to do, the drug remains the same, that is hydrocortisone, but the quantity becomes double, that is 50 milligram at induction. This is our first thing. Now, 50 milligram every 8 hourly for a period of 72 hours. So this is high yield concept. Now, after that, we will taper down to maintenance dose, whatever it was, which is in our scenario is 30 milligram per day. Now, the important thing is that why we are focusing on this, because if there is failure to provide cover for steroid during the perioperative time, then the most likely thing that can develop is the Addisonian crisis. Now, what is Addisonian crisis? So this is a high yield concept. Now, if you have a patient who was taking steroids and you failed to provide the cover in the perioperative period, then the patient will develop Addisonian crisis. So how the patient will present to you? They will present with decrease in the blood pressure. They will present with decrease in the GCS. Now, with the electrolytes, there will be a decrease in the sodium. There will be a decrease in the glucose. However, there will be an increase in the potassium value. Now, on the skin, in Addisonian crisis, the patient might develop some sort of pigmentation as well. Now, it is high yield to differentiate it from the septic shock or sepsis. Okay, so it is very high yield to differentiate from it. Now, what is going to be the features of sepsis or septic shock? Now, the high yield feature is there will be an increase in the glucose, there will be increase in the temperature, and there will be some sort of infection that can either be found in the wound or anywhere in the body. So it is high yield that for the Addisonian crisis, how you are going to manage it. So you're going to give intravenous hydrocortisone 100 milligram. So that is the treatment for the Addisonian crisis once it has developed. Beforehand, we have the quantities of 25 and 50. But if Addisonian crisis has developed, then we might be required to give 100 milligram intravenous. However, for the septic shock and sepsis, we will be required to treat the shock with fluids and might require inotropic support, and we can give the antibiotics specific to that scenario.